Thank you, Greg. The last time I stood in this lecture theatre, it was a concrete shell and I was wearing a hard hat supervising the construction of the building. But now it's time for something completely different, genetic aortopathies. So what is a genetic aortopathy? It can be defined as a heritable disorder of aortic mechanostructural homeostasis, consequent upon gene variants and characterised by abnormal aortic remodelling, aneurysm and dissection. That tells you its cause, its pathophysiology and its consequences. Now this is two good reasons why you should listen to this talk, and they're self-explanatory. The spectrum of genetic aortopathy, as Greg mentioned, has really expanded in the last 10 to 15 years. Marfan syndrome and bicuspid valve syndrome have been well known to all of us for a long time. Some of us have known about Turner syndrome, where you can get aortic dilatation in association with deletion of an X chromosome. And then there have been some new kids appear on the block, and they've actually made it quite a nasty neighbourhood. So Loeys-Dietz syndrome, due to mutations in the tissue TGF-beta receptor 1 and 2 subtypes. Ehlers-Danlos syndrome, known for many forms, collagen 3A1 is the vascular form. TAD, thoracic aortic aneurysm and dissection syndrome, due to mutations in a wide variety of smooth muscle and signalling proteins. TAD associated with early onset osteoarthritis due to SMAD3 mutations. And the male converse of Turner, Fragile X syndrome, is also associated with genetic aortopathy. And the interesting one, GLUT10 mutations, that's a glucose transporter, which leads to tortuous and aneurysmal arteries, and it's thought that what it does is impair glucose transport into the cell and change the glycosylation of transcription proteins. So we now know there are more than 30 gene mutations associated with aortopathy. Nearly all are autosomal dominant as best we can work out, but they can be grouped into certain systems that are affected. There are those that affect the extracellular matrix, such as fibrillin and collagen mutations. There are those that are associated with the abnormalities of the contractile phenotype of the vascular smooth muscle cells, actin and myosin heavy chain. And then there are those that are associated with a disorder in the conversation or signalling to vascular smooth muscle cells, such as the TGF-beta receptor and SMAD mutations. And I promise this is the only one of the molecular biology cartoons today. The extracellular matrix acts as a mechanotransduction system. In the invertebrates, fibrillin is a structural protein. It lost that role in vertebrates when elastin appeared, and it now acts as a force sensor. It modulates the availability of TGF-beta, and the TGF-beta itself interacts with a variety of related receptors on the surface of the vascular smooth muscle cell. The activation of those receptors leads to intracellular transcriptional cascades, which may be the canonical SMAD3, alternate through MAP kinase, or an alternate SMAD pathway. These influence the transcription of enzymes and synthetic processes within the vascular smooth muscle cell. They may be proliferative, leading to matrix deposition and fibrosis, or they may be destructive and degradative, leading to matrix degradation and dilatation. The balance in your aorta between the yin and the yang of matrix deposition and fibrosis and degradation will determine how rapidly you develop an aneurysm. The family of signalling proteins receptors is most interesting. You may wonder why people with Marfan syndrome are very tall and thin, and that's because the TGF-beta can have promiscuous signalling via alternate receptors that normally regulate bone and cartilage growth. You may wonder why people may have aneurysm osteoarthritis syndrome, because there is an interplay between the growth of cartilage and bone and the growth of the extracellular matrix in the aorta. The hallmark is Erdheim's cystic medial necrosis. Now, that's characterised by elastin fragmentation. Most of us who look at pathology are used to seeing that. For goodness sake, when you chop out a bit of aorta, please do check the pathology, because if it shows cystic medial necrosis as a dominant factor, even if the patient is 65 or 70, you are probably dealing with a genetic aortopathy. These cartoons of scanning electromicrographs show how you get degradation and destruction of the elastin lamellae and the fibrillin network with release of matrix metalloproteinases. And it's that degradation that underlies what we see on light microscopy. So how common is this? Given the size of the audience, it's odds on that someone here has a genetic aortopathy. They may or may not know it. The commonest is bicuspid aortic valve aneurysm. The next most commonest is sporadic TAD. You've then got familial non-syndromal TAD, our well-known friend Marfan syndrome, and the less common ones of aneurysm osteoarthritis. So you could very well ask yourself, what is my aorta actually doing at the moment? Marfan syndrome is the paradigm, long, tall, thin people who get fusiform or onion-like aneurysms of the aorta. I need to tell you that not all my patients with Marfan syndrome are either tall or thin. Some of them are short and stumpy, and they still have fibrillin mutations. It was the first of the genetic aortopathies to have the underlying genetic cause identified, and that's a mutation in fibrillin 1 on chromosome 15. Nonetheless, the diagnosis is a clinical one. Now, in the 25 years I've been doing this, the diagnostic criteria for Marfan syndrome have changed 3 times, but we now have the revised Ghent criteria, which are based upon correlation to fibrillin mutations. Now, these criteria place great emphasis upon the presence and detection of aortic dilatation, afibrillin mutation, and/or ectopia lentis. The musculoskeletal features are scored according to an internationally agreed scoring system, which is summarised there, which most people cannot remember off the top of their head. But if you go to www.marfan.org, it has a really helpful scoring sheet and a means of calculating the Z-score. We heard earlier on today comments about measurement of aortic size and the fact that the guidelines do not recommend normalisation to body surface area. The reason they don't is not because it's wrong, it's just because they haven't got any decent evidence to support making a recommendation otherwise. You need to calculate Z-scores. Your aorta differs in size according to your body size, it differs according to your age, and it differs according to whether you're male or female. So if you're going to determine how bad or otherwise someone's aortic dilatation is, you need to know how much it deviates from the predicted mean for that person, age, sex, and body size. That's the Z-score, which is the number of standard deviations. Most of us would take 2 standard deviations. If you're dealing with children under the age of 18, please take 3 standard deviations. But you can't always be sure. Even when you apply the criteria, we often see people who come along who've got some features, maybe yes, maybe no. Non-specific connective tissue disorder. They've got a bit of hypermobility, they've got some striae on their lower back, they've got long, thin fingers, but their aorta's not dilated. Please, once upon a time we used to say, no, we don't think you've got Marfan syndrome. We would not say that now, particularly if they're young. We'd get them back in 3 to 5 years' time and reassess. You will find that their aorta starts to get bigger. Hereditary ectopia lentis. There are some families where everybody's lens drops out, but their aortas don't dilate. They do have fibrillin mutations. Why these people are lucky enough not to get the aortic dilatation, we do not know. But they do not have Marfan syndrome. Marfan syndrome is a multi-systemic syndrome. These people have isolated hereditary ectopia lentis. And then there's mass phenotype, which is where you've got a little bit of mitral valve prolapse, you've got some musculoskeletal findings, but your aorta's not dilated. Some of these people have fibrillin mutations, some don't. Their prognosis is quite benign. And the key for these people is they do not have ectopia lentis and they do not have aortic dilatation. Now, I want you to know that Marfan syndrome is more than the aorta. We've moved down and we're starting to take over the ventricle. In the 25 years I've been in practice, I've only ever sent 3 patients for heart transplant. They all had Marfan syndrome. Marfan syndrome is associated with impaired left ventricular function in a significant number of people. And so this is a study that we've been just about to publish, looking at end-systolic pressure-volume relations in Marfan syndrome compared with controls and hereditary TAD. Please note that the worst affected ones are Marfan syndrome, where there is a reduction in slope of the end-systolic pressure-volume relation, which is an index of impaired contractility. There may also be some impairment in TAD, but Marfan syndrome are clearly the ones most affected. 25% of people with Marfan syndrome have easily observable impairment of left ventricular function. The take-home message for these people is they do not tolerate mitral or aortic regurgitation the way other people do. So the parameters that we are used to using for determining timing of valve intervention in the general population with MR or AR need to be reappraised for people with Marfan syndrome. They fall out the door if you don't fix their mitral regurgitation if it's moderate or more. This has also got prognostic significance. We're in the process of writing up the paper about that, but it is an additional adverse prognostic indicator for people with Marfan syndrome. Now, there are things that look like Marfan syndrome, and they are not nice to have if you can avoid it. Loeys-Dietz syndrome is the first of them. Now, Loeys-Dietz syndrome is characterized by musculoskeletal findings and a rather aggressive aortopathy. Typically, in Marfan syndrome, you have dilatation of the aortic root, the ascending aorta, and the proximal descending aorta. Loeys-Dietz is characterized by ectatic dilatation, not just of the aorta, but of second and third generation conduit arteries. So if you look here, there's a common iliac artery aneurysm, there's this hugely ectatic aorta, mesenteric arteries aneurysmal, the iliac arteries are dilated. These people have a much broader arteriopathy. It extends from the top of their head down to their knees, and they require investigation and follow-up of their entire arterial tree. They also have some very interesting musculoskeletal findings: hypotelorism, which is wide-set eyes, blue sclerae. Those of you that remember osteogenesis imperfecta, they have blue sclerae. This is the crosstalk between the bone morphogenic protein pathway and the TGF-beta pathway. They don't get ectopia lentis. They do have the musculoskeletal features of Marfan syndrome. They can be a little difficult to tell apart. Having said that, I've got people with Marfan syndrome and Loeys-Dietz syndrome, mutation proven, who would sit in this audience and look no different from you or I. One of the easiest things that I have found for some of the people with Loeys-Dietz syndrome is they have downsloping palpebral fissures at their eyes and they look perpetually tired. This is the classic features. You do not usually find these features. Be alert for the non-cardiac presentations of these things. Everybody knows about the ectopia lentis with Marfan syndrome, and we've talked about the musculoskeletal. Recurrent pneumothorax is common in young men, but it can be a feature of Marfan syndrome. Centrilobular emphysema in a young person who is not a smoker is probably, if it's not alpha-1 antitrypsin deficiency, is probably Marfan, or even more likely Loeys-Dietz with a TGF-beta problem. Sleep apnea, because they have an abnormal long face. CSF low pressure syndrome. The headache when I get up in the morning, it goes away when I lie down, and everyone thinks you're a PF and you don't want to go to work. It's not. It's a leak from your ectatic cerebrospinal dura, and you end up with a CSF low pressure syndrome and a postural headache. Subarachnoid hemorrhage due to an intracranial aneurysm. Everybody who ends up in ICU with a cerebral aneurysm needs to be evaluated for a genetic aortopathy. It may be TGF-beta, it may be ACTA2. It is out there. Early onset varicose veins, particularly in young men, and I don't mean the big knobbly snake-like veins, I mean the next generation down spider-like veins over the dorsum of the foot and the lower calf, and also over the costal margin, is a giveaway. And finally, if you're into gastroenterology, eosinophilic esophagitis. Loeys-Dietz syndrome is more aggressive than Marfan syndrome, as shown here on this survival curve. They tend to have aortic events and dissection events 10 years earlier than Marfan. What about bicuspid aortic valve? It's been talked about a lot today, and we're aware of the variable phenotype, everything from aortic coarctation, interrupted aortic and hyperplastic aortic arch, through to ascending aortic aneurysm. First take-home message, 30% of first-degree relatives are likely to be affected. The aorta is generally enlarged in most people with bicuspid aortic valve, and please note that your aortic size is related to your height. And if you're dealing with children and adolescents and they're still growing, you need to take account of their body size in evaluating what's going on with their aorta. Now, what about the heritability of bicuspid aortic valve? This was the first paper that pointed out that bicuspid aortic valve was heritable, and it's commonly accepted now that about 30% of cases are. I'd like you to have a look at the pedigrees on the right here. It is commonly said that bicuspid aortic valve is associated as autosomal dominant with incomplete penetrance. Many people have looked to try and find the gene responsible. It is, after all, a very common abnormality. For all of that, there have only ever been isolated reports of genetic variants in Notch1 or GATA5 transcriptional regulators, and everybody else has turned up nothing. If we look at the little pedigree here, that could be very easily interpreted as straight autosomal dominant inheritance. Fair enough. If we look at the pedigree at the top here, that tells you that it cannot be X-linked, because there are two affected parents and the girl is unaffected. But the pedigree down the bottom could be autosomal recessive. So what's going on? Let's go back to what was said earlier on about the valves and the aorta. And I will put it to you that bicuspid aortic valve disease is not one disease, it is at least three. There are three different aortic phenotypes, and that's been alluded to, where the sinuses dilate, where the ascending aorta dilates, particularly where there's a very little tubular hypoplastic aortic root and a dilated ascending aorta, and then when the whole box and dice dilates, and the variability in the aortic valve. And so it is highly likely that the genetics of bicuspid aortic valve are not one gene variant, but the way a genetic switchboard of probably half a dozen genes is set. And whether your switches are set up or down will determine whether you get a bicuspid aortic valve with or without the aneurysm and what it is. And you inherit the switchboard from your parents. They may or may not alter the switches for you. So this is the new era of developmental genetics that we need to understand. It's not a simple linear yes you have it or yes you don't. It's well probability according to your genetic switchboard. When we look at those with familial BAV versus non-familial BAV, please note that they can have other abnormalities associated with it. For every family with BAV, you'll probably find about 3 other affected members, and that echoes our experience both in BAV and in TAD, as we'll talk about in a minute. So one day I was in the office, this lady came in, it wasn't this lady, she looked like this. She came in to see me and she said, hi, she said, I want you to replace my aorta. I'd never met her before. I said, right, okay, do you want to tell me why? She says, 42 millimetres. I said, we don't normally replace them at 42 millimetres. She said, this is why I want you to replace my aorta. Her father had died of dissection at 73. Well, he was 73. She had a dilated aorta, not really an aneurysm, it was only 42 millimetres. She had 3 brothers who had dropped dead of aortic dissection. And we subsequently found there's 2 more in the family in the next generation. She said, I'm not waiting to join my brothers. I said, I'll see what you mean, I'll send you to the surgeons. This lady did not have Marfan syndrome, she did not have Lewis-Dietz-Ehlers-Danlos, and she didn't have a bicuspid valve. She had TAD. And this is the big, ugly, hairy elephant in the room. TAD cannot easily be diagnosed by any external physical features. If you're really good with a stethoscope and you hear there's a loud hollow A2, that's the sign of the aortic root aneurysm. No murmur, just a hollow A2. But otherwise, they usually, the lucky ones get picked up with a CT scan or an echo for something else. The unlucky ones present dead, usually young. Once upon a time, we used to think that people presenting with dissection in their 70s were just bad luck, getting old, bad blood pressure they didn't know about. So I had a guy like that many years ago. We looked after him. He did very well, lived for years, until one day he came to tell me that his son had died lifting weights in the gym from an aortic dissection. And then I looked at his grandchildren, they had aneurysms. So there is no upper age limit. And this thing is really nasty, because you can't pick it. It's due to one of the many mutations we talked about. Now, sometimes families say, oh yes, we've got a bad history of heart disease, but he died of a heart attack, he died of a stroke. So one of the first mutations associated with TAD was ACTA2, vascular smooth muscle cell actin. Now, there's emerging evidence to say that ACTA2 is not one you want to have a mutation in, because this description of the families showed that it's associated not just with thoracic aortic disease, but with premature coronary disease and stroke, and if you ever are lucky enough to see Moyamoya disease, which is an intracranial occlusive disease with new capillary angiopathy growth around the base of the skull. It looks very pretty, but you don't want to have it. Look, these people get premature coronary disease, they get premature stroke, or they get aortic disease. And I get histories from families where they say, oh, he didn't have a dissection, but he died at 35 of a heart attack. Or my mum had a stroke and her sister had a stroke. Or they talk to them, anyone ever had a cerebral bleed? Oh yeah, everyone on mum's side died of cerebral hemorrhage. This is not bad luck or idiopathic. These things are aggressive vasculopathies that are much more protean in their manifestation than we had realised. We can relate it to defects in the ACTA2 protein, and so ones up in this subdomain might cause stroke, and ones down here might cause early coronary disease. They all cause aneurysms. So this leads us to broaden where we're looking at in these people. Familial thoracic aortic aneurysm. 9.3% of families had people who had an intracranial vascular event. The events are more common in women, while the aortic events are more common in men. Routine cerebral and aortic imaging could prevent cerebral hemorrhages. So, you're not just going to look here to here with an echo. It's here to here, MR or CT or either. Aneurysm osteoarthritis syndrome. The young people who've always got sore joints, they haven't got a positive rheumatoid factor, everybody thinks they're trying to get out of sport. Kind of slightly funny looking kids, got a flat face, squat nose, maybe they're just not all quite right. They have mutations in SMAD3. Remember the downstream pathway from TGF-beta. And in particular, they get aggressive aortic disease. They get an early onset arthritis. There's that bone connection again. They have craniofacial features, and the ones I've seen, they look a little bit like Down syndrome, but not quite. And they have some of the other features of Marfan syndrome. It's not a good aortopathy to have. 71% of cases had a root aneurysm. Aneurysms in 1/3 in other arteries were tortuous arteries. 15 deaths at a mean age of 54 years. So these people are getting into trouble in midlife with a genetic aortopathy that's been simmering away all those years. And these are some of the illustrations, and you can see there's the aortic root dilatation, the prominent iliofemoral arteries, the tortuous intracranial arteries and aneurysms. So when you get someone, when you've made a diagnosis of TAD, you must screen the relatives. You must take a detailed family history, which may guide you to genetic testing, and you should look for giveaway features in the musculoskeletal or other systems that tell you what you might be dealing with. So, what happens to these people? This is one of the early papers that was cited for the 50 millimetre cutoff for operating in Marfan syndrome, because it showed that your event rate, if you've got Marfan syndrome, goes up after 50 millimetres, which is great, until you look at the fact that the number of people was not very many, and the number of events wasn't very many. So maybe that's not so reliable as we had hoped. So this is what we've found looking over 20 plus years in people with these different aortopathies. And this is your risk of dying from whatever cause according to your aortopathy. And Marfan, the medians, this is all comers. Median survival is now just under 70 years, and it's getting better all the time. TAD is frame shifted about 10 years, and BAV do pretty well. All of them have high adverse event rates. In BAV, it is largely driven at early age by intervention upon the valve. In the others, it's driven by intervention upon the aorta. Look at the risk of dissection. The risk of dissection in BAV is not zero, but it is much less than it is in the other aortopathies. The risk of dissection in TAD is every bit as bad as the risk of dissection in Marfan. Now, size does matter, but there is not a hinge point. Everybody quotes the data from Yale about the hinge point. It is not very applicable. That data was obtained in people with predominantly hypertensive and atherosclerotic disease with a mean age of over 70. What we find here is that there is a continuum of risk for death or dissection as your aorta gets bigger. Can we stratify the risk any better? And here's where family history is important. Some families are clearly dissectors and others are not. If you have an aorta of less than 45 millimetres, whether or not you have a family history of dissection, you don't do too badly. But if your aorta is over 45 millimetres and you have a family history of dissection, you're in trouble. Moral of the story, don't wait to 50. Similarly, for Louis-Dietz syndrome and for ACTA2 mutations now, the recommendations are to operate at 45 millimetres. For women who want to get pregnant, you should, with Marfan or Louis-Dietz, you should operate and replace their aorta before 43 millimetres. So, just before we quickly finish up, some ugly lessons from experience. Certainly, the more you look, the more you find. Normal is not normal, and you do need to be wary of the fact that the genes can play tricks on you and appear to be genotype positive, phenotype negative, and the manifestations differ between men and women. Somebody asked earlier about medical therapy. So a quick summary on medical therapy. First and foremost for medical therapy, screen and detect everybody at risk you can get your hands on. Once you find somebody who is affected, you plug them into a surveillance program. As I say to the patients, it's like the old Hotel California. When you join Club Aorta, you can check in, you can never leave. Surveillance keeps people alive. Detection keeps people alive. People going off into the donga and sticking their head in their sand die. Physical activity. We've heard about not playing body contact sports. There are some pretty restrictive things about driving motor vehicles, and you cannot fly aircraft, which was an issue for a guy I saw yesterday afternoon whose career aim is to fly an F-22 Raptor. Medical management. Well, everybody puts them on beta blockers. The evidence base is poor. There have been a number of studies. Most of them have less than 20 patients in them. The one that everybody quotes is the Shores study from 1994. In summary, the evidence from beta blocker studies is that they may slow down the rate of aortic dilatation. There is absolutely no evidence that beta blockers change the clinical course or prevent dissection or sudden death. The average rate of dilatation is quoted at 1 millimetre a year for all comers, usually Marfan, and the beta blockers may roughly halve that. What about angiotensin blockers? If you're a transgenic mouse with a particular mutation in TGFBR2, angiotensin blockers are very effective. There have been 2 clinical studies done in Marfan, with angiotensin blockers. The first was the COMPARE trial, which was done in young adults, and it showed that treatment with losartan resulted in a halving of the rate of aortic dilatation. There was no effect on prognosis. The next was a study done in children and adolescents using losartan compared to beta blockers, and it showed that there was no difference between beta blockers and losartan. Both of them seemed to slow down. Both of those trials have been criticised methodologically, somewhat predictively. In summary, we use beta blockers with or without angiotensin blockers as best tolerated. The patients with Marfan in particular tend to have low blood pressure. It's very hard to titrate the dose. Although the clinical trials have been done with losartan, the benefit appears to be a class effect, and my colleagues in Johns Hopkins have told me they use candesartan. I use candesartan because it's on the PBS, it doesn't cost a fortune. Please do not use calcium channel blockers. They have never been shown to be of any benefit. Dihydropyridine calcium blockers actually may make the aneurysm growth worse. If you need to add another agent for blood pressure control, please use hydralazine. And there is no sound evidence base for anything in the other new syndromes because we haven't had them around long enough. Thank you very much.